Good evening, everyone. On behalf of my co-chair, Professor Van der Gijnst of the Department of Internal Medicine of the Université Libre de Bruxelles, and myself from the Department of Dermatology of UZ Leuven, we'd like to welcome you on this webinar on neutrophilic dermatosis and Behçet's disease. Before starting the scientific program, I would like to go through some practicalities. First of all, as you can hear, the presentations will be in English, but you have the opportunity to choose your own language. There is simultaneous translation. You just have to choose the tops on the top of your screen. You have the buttons where you can choose between Dutch, French, or English. Secondly, you can put your questions that arise during any presentation in the chat box below the screen. We will gather them together and present them during the Q&A sessions. So I think now it's time to start with a very interesting scientific program.
Good evening, everybody. Good evening, Petra. And to start this scientific session, it is my pleasure to introduce Professor Dr. Christos Zouboulis, who is Director of the Departments of Dermatology, Venerology, Allergology and Immunology in Dessau Medical Center in Germany, and is also a professor of dermatology and venerology at the Brandenburg Medical School. So his talk for tonight will be about Behçet's disease, and the audience is yours, Professor Zouboulis.
Dear colleagues, good evening, and thank you so much for the invitation to discuss with you on a rare disease named Adamantiadis Behçet's disease. Adamantiadis Behçet's disease is a rare disease with worldwide distribution, but strongly varying prevalence. Certain ethnic groups are mainly affected. A genetically determined disorder with a probable environmental triggering factor. This is the current concept of pathogenesis. There is a multi-system occurrence with oral aphthous ulcers, genital ulcers, papulopustules, erythema nodosum-like lesions, uveitis and arthropathy being the most common signs. The disease is an inflammatory disease representing a neutrophilic vascular reaction or vasculitis. You can see here the picture very clearly shown in the histology. It is a chronic, relapsing, progressing course and potential poor prognosis disease, especially in the males with systemic presenting signs and a mortality of up to 6%. In very severe lesions, here you see a lesion at the genital area, you almost don't recognize healthy skin anymore. The entire skin is infiltrated initially by neutrophil granulocytes and later on by mixed infiltrate. While we believe that Adamantiadis Behçet disease is well represented by certain lesions like oral aphthous ulcers, genital ulcers, eyes, arthritis, and vascular involvement, there are more lesions that can be found in a patient with systemic disease. So these are neurologic manifestations, especially CNS involvement, cardiac involvement, arterial aneurysms, gastrointestinal involvement, and phlebitis, thrombophlebitis. In addition, in males, prostatitis, rarely kidney involvement, and lung involvement. This slide shows the prevalence of the disease, especially prevalent in the Arabic countries and Eastern Asia, and of course the maximum prevalence we find in Turkey. We believe that there is a kind of a silk root disease starting from somewhere in the area of Xinjiang in China and going through the traveling of all tribes up to the Mediterranean area and also in Europe. If we look the epidemiology in Northern Europe, which we have from 0.1 to 1.2, it's very clearly a rare disease. In Germany, the country where I work, we have 1.1 per 100,000 inhabitants and 0.5 among inhabitants of German origin, so the half. The incidence is 0.8 to 1 per 100 inhabitants in a year. We have a manifestation peak at the third decade of life. There is no sex predilection, despite the fact that there are reports for sex predilection, especially in the Arabic countries. And if we go to East Asia, we have more women. It's exactly the contrast, but overall, we don't have sex predilection. The complete disease manifestation occurs into 2.9 years after the onset of the disease, with a median of 3 months. We don't have biomarkers, and the diagnosis is based on clinical criteria. If we try to summarize the pathogenesis of the disease, we have a genetic predisposition. We have probably either an infection or an environmental factor. We have a late immunological reaction, and we have damage and malfunction of the vascular endothelium. We have discussed over the years that a gene should be involved. The area that maybe is responsible for Adamantiadis-Behçet's disease is located at the major histocompatibility system on the short arm of chromosome 6, 6p21.3. And you can see here exactly the localization where we believe that this gene could be the so-called MIC-B area. And it is very near to the HLA system, especially near to the HLA and B system, especially HLA-B51 being the most common HLA antigen seen in patients with Adamantiadis-Behçet disease. The second one is A2. If we discuss about a bacterial infection, there are data from Japan showing an infection with Streptococcus sanguinis, which dominates the flora of patients' oral mucosa. A chronic infection concept with an AGA protease producing Streptococcus sanguinis species that have been proposed because this is recognized as an own antigen, and later on there is an immunological reaction to that. And especially the BES1 Streptococcus gene codes a 95 kilodalton large antigen, which is associated with the disease. So this is exactly the antigen that we consider that induces the disease at the late immunological reaction. In Germany, we have found that Mycoplasma fermentans induces mucosal infection. The Mycoplasma is strongly associated with an activation of macrophages. The MALP404 antigen bears a motif which is very common with HLA51, which is common as discussed in the patients with the disease. And 32% of 22 German patients tested for MALP404 were positive in comparison with none of the matched controls. If we look at what is going on in the tissue, here you see that we have tissue and we add lymphocytes of patients, including serum of patients or not, and you see the very strong infiltrate in ex vivo studies, and you see that the patient's serum should be some kind involved, and because it induces more binding of lymphocytes to endothelial cells of the tissue in the experimental model. Trying to summarize the knowledge on the pathogenesis at the level of the endothelium, we believe that there are circulating antibodies against a specific endothelial antigen that activate the vascular endothelial cells to produce cytokines. Let's go through it. We have a circulating IgM antibody. It binds on the surface of the endothelial cells without killing them. We don't have cytotoxicity. This antibody that binds is a 44 kilodalton endothelial cell membrane antigen. It's called human alpha enolase. And this induces interleukin-8 synthesis, making the endothelial cells to behave like a professor inflammatory cells, and we have then accumulation of real inflammatory cells and acceleration of inflammation. Other antigens that have been found in different experiments are tropomyosins or kinectin 160 kilodalton polypeptide. The major pathogenetic factors show that there is a complex genetic background, there is a pro-inflammatory activation of the intrinsic immune response, and we have an additional adaptive immune response against environmental and autoantigens. We discussed that the diagnosis of the disease is made by clinical criteria. A collaboration of 27 countries has developed the international criteria for Behçet's disease, ICBD, which are now the major diagnostic criteria with the highest sensitivity and specificity. Which are these criteria? Are oral manifestations or oral aphthous ulcers with 2 points, genital aphthous ulcers with 2 points, ocular manifestation with 2 points. So these are the 3 major, 2 of them in dermatology, 1 in ophthalmology, and then we have skin lesions, 1 point, central nervous system manifestations, 1 point, vascular manifestations, 1 point, and if we have a positive pathogen test, it's added. And this from 4 points, more than 4 points, we have an indication for the disease. The interesting story in this criteria is we have abandoned the obligatory presence of oral aphthous ulcers, which was permanent almost in all previous criteria, and we have added the very serious CNS manifestations and vascular manifestations, allow us to diagnose quicker a disease, especially in very severe form. However, the oral aphthous ulcers still are the onset manifestation of the disease. We see here patients have been diagnosed. These are patients of the German Registry of Adamantiadis Behçet disease. In 83% of the cases, the disease starts with recurrent oral aphthous ulcers. There is no typical clinical picture of the oral aphthous ulcers in Adamantiadis Behçet disease. You can find them at the angle of the mouth, at the buccal mucosa, at the side of the tongue, at the top of the tongue, lesions similarized in squamous cell carcinomas, and of course multiple lesions. The most important clinical sign is that these lesions are recurrent. If we look, the median duration of onset manifestation to diagnosis in Adamantiadis Behçet disease, depending on the first manifestation, it's clear that the quickest way to diagnose the disease is if we have ocular involvement. The reason is simply because the lesions we see at the periphery of the uvea are very characteristic. But then, of course, dermatological manifestations make the diagnosis. The latest diagnosis is if, it's not many cases, but if the arthropathy is the leading symptom because it's not specific at all. What is important is to know which are the manifestations that they are specific. So we have severe complications, and these are blindness in almost 6% of the patients, meningoencephalitis, severe arthritis. We have also patients that die, 1% at least at the German registry, hemoptysis, and gastrointestinal perforation. The discussion about HLA-50B51 is always what is exactly its role. It is a diagnostic marker, it is not. However, it is a marker that indicates severe prognosis. So HLA-B51 positive patients, so patients who are HLA-B51 positive present more severe disease than HLA-50 or B51 negative ones. Now, which are the factors that have to be taken into consideration for earlier treatment? First is sex. Males have a more severe prognosis than females. The age at onset manifestation in early age indicates more severe disease in the future. The symptom severity, so in mild symptoms we don't need intensive medical treatment. And the probability of recurrence. Many recurrences lead to irreversible damage. This is why we need to treat earlier. If we make the pyramid of treatment, initially the first treatments are colchicine and corticosteroids. We have a reduction of oral ulcers, but we don't have always a satisfactory effect. Then we go to immune suppressive agents used in levels 3 to 5. Randomized control studies, however, are missing. We have limitations through side effects, and we have patients who, not rarely patients, who fail to respond. And we use them in case that earlier treatments have failed to respond, and of course we have to change if patients do not respond to these drugs. Now, off-label agents for Adamantiadis Behçet's disease is adalimumab. It's very clear here to know that the drug is registered for posterior uveitis. So if we have Adamantiadis Behçet's disease with ocular involvement, we have to prescribe the drug for the ocular involvement, but not for Adamantiadis Behçet's disease. The infliximab is still off-label. It covers, however, ocular, CNS, gastrointestinal tract, and vessel involvement. One new drug that has been registered in many European countries for the recurrent oral ulcers and Adamantiadis Behçet's disease is apremilast, an oral phosphodiesterase 4 inhibitor. It increases the intracellular cycling AMP level in immune cells, and it shows a good response to the mean oral ulcer count over 64 weeks. And you see it's a symptomatic treatment actually, because after you discontinue treatment, you have, in many cases, a recurrence. A very important issue is what is about the prognosis through an early systemic treatment. These are data from the German Registry of Adamantiadis Behçet's disease. When we started, it's almost over 30 years ago, we had severe complications in 42% of the patients coming in to be registered. Nowadays, including the old cases where we have severe sequela, we have a reduction of the severe complications down to 9%. Again, when we started, we have every third patient being at a level that we could call blindness, as a loss of vision at the level of blindness. Including the blind patients of these times, the entire registry has now only 2% with blindness, which is still a high digit, but a huge improvement in comparison to the initial work. And regarding the lethal outcome, when we started the first years, we have an average of 7% lethal outcome, going down, including the data of these studies, to 1%. So practically, we don't have a lethal outcome in the last approximately 20 years. I would like to summarize. We have a profound inflammatory response, which is triggered by infectious environmental agents in a genetically susceptible host. We have a late-type immunological reaction, which leads to manifestation of the disease signs. We have circulating pro-inflammatory antibodies and small vessel endothelial cells, which are primarily involved in Adamantiadis Behçet's disease, and new treatment modalities are emerging. One of them is the lately registered apremilast for recurrent ulcers of disease. This data and this work would not be possible if the very intense work of the last years on rare diseases will not take place. We are part of the European Reference Network on skin, and Adamantiadis Behçet's disease is representing rare vasculitis in this context. We're part of the National Action by Association of People with Rare Disease in Germany, NAMES, also at the Middle Germany Competency Network of Rare Diseases. In our medical center, we coordinate the acquired immunological low prevalence and complex adult skin diseases of the skin inside the European Reference Network skin. So we are the group of Allocate skin inside the ear and skin. And the German Registry on Adamantiadis Behçet's disease, which is an official association according to German law, is working since now 32 years providing all the possible support to physicians and patients with the disease. Thank you so much for your attention, and I would be very glad to receive your questions.
Hello again. In addition to this nice presentation of Professor Zouboulis, I would like to inform all of you that actually in Belgium we now have the reimbursement of apremilast for the indication of oral apoptosis in Behçet's disease. It would be interesting if my slides appear for the for the audience. As already mentioned by Professor Zouboulis, apremilast was approved by the FDA and the EMA for the indication of oral apoptosis in adult Behçet's patients, and this was based on a phase 3 registration study, the RELIEF study, showing a decrease in number and especially in pain of the oral ulcers, and this is a quite fast effect actually. In the meantime, these results of the registration study were actually confirmed in real-world data, and now we are very happy that in Belgium we have the opportunity to prescribe it to our patients. These are the criteria that you have to fulfill to prescribe it here in Belgium. You have to have a patient that is 18 years or older, and he needs to have the diagnosis of Behçet's disease based on the international study group criteria. These are different criteria as the ones that Professor Zouboulis just mentioned. There are different types of diagnostic criteria. And actually in the international study group criteria, the patient needs to have recurrent oral ulcers, at least 3 episodes during a year, and in addition needs to have 2 of the following criteria, being either recurrent genital ulcers or some specific skin lesions like erythema nodosum or the papulopustular kind of lesions, or a positive result in a pathogen testing, or having specific eye lesions such as uveitis or retinal vasculitis. So if based on these criteria you can confirm that your patient has a diagnosis of Behçet's disease, you can apply for a reimbursement if he has at that time point 2 active oral ulcers that do not respond when there is no response to topical treatment or no response to colchicine treatment, or your patient is intolerant to colchicine or has contraindications for colchicine. So then you can apply for a reimbursement that you can get for 6 months, and afterwards you can go for a prolongation, and then it will be 12 months. The dosage is the same as for psoriasis, what we all know, 2 times 30 milligrams a day with a short titration the first 5 days. And these are the forms that are available on the RECIF side or the INAMI side, where you can ask the first reimbursement approval and another form for the prolongation. It's important to know that if you want to prolong the reimbursement, the only thing you have to confirm is that the patient is clinically better with apremilast. Besides the forms, you can also ask for the reimbursement in the CVAR system, the online system where you get the confirmation very quickly. So I think it's a privilege that in Belgium we have now the reimbursement of this apremilast, which can, although it's a rare disease, but in those patients it's very nice to have now this treatment option. So we will now see if we can reach Professor Zouboulis for some questions.
Yes, I'm afraid that there is right now a technical issue, so that Professor Zouboulis is not reachable. But I think that we will move to the second presentation from Professor Marzano, who is also recorded. And Petra, do you agree to introduce Professor Marzano from Milan?
With pleasure, with pleasure. So we will now have a talk on the neutrophilic dermatosis, which is not just one disease, but a group of diseases. and Professor Marzano from the University of Milan and the head of the dermatology unit of the Ospedale Maggiore Policlinico in Milan will present us the neutrophilic dermatosis. He's an expert in this field for many years, and I think he's the ideal person to guide us through this quite intriguing but complex group of diseases. So we're really glad to have you here, Professor, for your talk.
Dear colleagues, good evening. It's my great pleasure to be here with all of you, and so I would like to thank Professor Del Marmol for kindly inviting me to this very nice meeting, the meeting of the Société Royale Belge de Dermatologie et Venereologie. And I will talk about neutrophilic dermatosis, providing you with the new insights on this very fascinating topic. And so you can read my conflict of interest, and so I would like to start with the definition of neutrophilic dermatosis, which encompasses a wide spectrum of conditions marked by accumulation of mature activated neutrophils in the skin and rare internal organs. The cutaneous manifestation of MD are typically polymorphic, including pustules, abscesses, papules, nodules, plaques, blisters, and ulcers, and almost any organ system can be involved, giving rise to the term neutrophilic disease, coined 7 years ago by the friend of mine, Daniel Vallac. So here you can see the main aspects of this fascinating group of disorders, so accumulation of neutrophils in the skin and possibly, albeit rarely, of the internal organs with systemic inflammation, the sterile nature of the lesions at the onset, of the skin lesions at the onset, but they can have superinfection during the course of the disease, and a very important aspect which is the clinical pathological similarities to autoinflammatory diseases, and so the role, the core role of the key role of autoinflammation in the pathogenesis of this group of disorders. So this is the classification of neutrophilic dermatosis, including a superficial or epidermal setting in which the prototype is Nedo Wilkinson disease, but also another rare condition which is amyocrobial pustulosis of the folds, and I will talk about this entity later on, and also GPP, generalized pustular psoriasis, in this setting, which is characterized by a pustular presentation, and so this entity is fashionable, considering the fact that we will have a new drug, a new biologic, a selective biologic to treat this condition, and I will talk about shortly about this kind of treatment. So the second setting is the plaque type or dermal setting whose prototype is Sweet syndrome, and then the deep or hypodermal group whose prototype is pyoderma gangrenosum. Pyoderma gangrenosum is the king of this setting and of the neutrophilic dermatosis in general. And so I have added to this initial classification another group of forms, the so-called hypodermal, dermal, epidermal neutrophilic dermatosis, in which among whom there is syndromic PG or syndromic HS, and I will talk about this condition too. And so these slides show you the three prototypic forms of Nedo-Wilkinson disease, Sweet syndrome, and pyoderma gangrenosum with the relative histology. And so this slide is nice, in my opinion, because it's focused on the evolution of the understanding of ND, starting from 1964, when Sweet described the acute febrile neutrophilic dermatosis, also then subsequently known with the eponym of Sweet syndrome, up to 2016, with the view of neutropenic dermatosis as autoinflammatory diseases. So PG is the king of neutrophilic dermatosis. It is a rare disease in which this disease presents most frequently in older individuals, and there is an higher prevalence and incidence of PG in women as compared to men, but the most important finding of this epidemiological slide is the fact that the disease is burdened by a severe morbidity and is associated with an increased mortality. So the variants of PG, the classic ulcerative one, but also a number of other possible variants, so the bullous, pastoral, vegetating, peristomal and postoperative, and so it's possible to have skin lesions belonging to the different variants occurring concurrently in the same patients. So this is an important paper written by a panel of international experts of PG, and I was in the authorship of this paper. I'm very pleased about it. And so there is this paper includes the validated diagnostic criteria for the diagnosis of the ulcerative classic PG, and so there is a major criterion which is the demonstration of a neutrophilic inflammatory infiltrate, a neutrophil-rich inflammatory infiltrate on histology, and a number of other important criteria, so the pathology phenomenon, so as you know very well, the occurrence of the typical ulcer upon trauma, either accidental or surgical traumas, and so the association with IBD or inflammatory arthritis, and the clinics with the very characteristic features of the skin ulcer, which has undermined erythematous violaceous borders, and also the possible presence of erythematous and erythematous halo, and also the mode of resolution of the ulcer with the so-called ring of paper appearance, as well as the exadjuvantibus criterion of the response to immunosuppressive agents. In PG, but in neutrophilic dermatosis in general, it's possible to have, although rarely, involvement of the internal organs, and this is very rare, because I had just a patient with there was kidney involvement, and this patient responded well to systemic corticosteroids, immunotherapy, both in terms of resolution of the ulcerative lesions and resolution of the kidney involvement. But I had also a patient with lung involvement, and this patient unfortunately died due to septic complications. So the group of Langan conducted a study on a large cohort of patients with PG, more than 300 patients, and so there was an association in this cohort with IBD in 20% of the patients, rheumatoid arthritis in 12% of patients, and hematological disorders in 4% of the patients. And this is in line with a paper published by my group the year before on a smaller cohort of patients with PG. So a fascinating topic is drug-induced PG. Here is the list of drugs reported as triggering factors for pyoderma gangrenosum, but I don't want to comment in detail this list, of course. But so there is the category, the important category, which is represented by the imatinib or the tyrosine kinase inhibitors, and used for the treatment of lymphoproliferative disorders, but also biologics, in particular tumor-associated factor alpha antagonists, used for the treatment of concurrent IBD, for example, and this kind of PG may be regarded as a paradoxical reaction to these agents which are used to treat refractory PG, and so it's the same that as in the paradoxical reactions to tumor factor alpha agents with a pastoral presentation. So PG may be associated with cocaine in cocaine abuser, and you can see the very impressive cutaneous manifestation with aspects of ulcerated PG, but also vegetating PG, and it's curious that these patients have elevated titers of p-ANCA antibodies, but they represent, in my opinion, just an epiphenomenon because they are not pathogenetic as in the group of vasculitis such as Wegener granulomatosis, nowadays named granulomatosis polyangiitis. And you can see my patients with imatinib-induced PG. These patients had chronic myeloid leukemia. You can see the impressive manifestation, the impressive lesions of PG. So that affected the sites of HS, but I made the diagnosis of pyoderma gangrenosum due to the characteristic of the ulcer, and in particular the deepness of the ulcers, and then you can see the complete healing of the ulcers after withdrawal of the drug of the imatinib. So another important paper is this paper published in New England Journal of Medicine by Mark Davis, so the chair of the Mayo Clinic, and so this paper is focused on the mimickers of PG, and so there is the group of vasculitis, in particular granulomatosis polyangiitis, as said before, but also lymphomas. I remember patients in which I made the diagnosis of pyoderma gangrenosum clinically at the bedside, and then with the results of the histopathological examination and immunohistochemistry and molecular biology, the diagnosis was that of anaplastic CD30 positive large T-cell lymphoma in that patients. And moreover, there is the group, another important group is the group of fungal infections, such as polotrichosis, for example, but it is the case in particular of countries of the world in which these fungal infections are frequent. The pathogenesis, we published together with Emmanuel Maverakis this paper in Nature Review of Disease Primers, and we discussed also the complex physiopathological scenario of the disease, and so there is the overlap with autoinflammatory diseases, and so the role, we discussed the role of autoinflammation in the pathogenesis of the disease, and so of the altered innate immunity dysfunction as core in the pathogenesis of this group of forms. Here you can see the model of autoinflammation applied to neutrophilic disorders, and so mutations involving, for example, PSATP1 can induce an activation, an altered activation of the inflammasome, which is the molecular platform playing a pivotal role in the autoinflammatory process. This structure is responsible for the proteolytic cleavage of the pro-IL-1 beta to the active isoform IL-1 beta, which accumulates in the skin and in the other affected organs, leading to the autoinflammatory process together with, so via a crosstalk with a number of other pro-inflammatory cytokines such as, for example, IL-17 or IL-23 or FUS, the telomerase effector alpha. So we demonstrated just an overexpression of IL-1 beta in the lesional skin of patients with PG and also with Sweet syndrome in a lesser degree, and an overproduction also, an overexpression also of the receptor for IL-1 beta, but also another pro-inflammatory cytokine which is IL-17, and an overexpression of a panel of cytokines with chemotactic properties, so able to recruit and activate neutrophils, in particular IL-8. So the genetic of neutrophil dermatosis compared to the monogenic autoinflammatory conditions such as CAPS, in which the skin lesions are urticaria-like lesions, or also DITRA, which is a form with pastoral presentation. I will talk about DITRA later on shortly. So I and my group concluded, demonstrated a number of mutations involving different autoinflammatory genes, such as the gene of familial Mediterranean fever, the genes of cryopyrinopathies, CAPS, the NOT2, which is related to Crohn's disease, or PSTP1, the PAPA gene, the so-called PAPA gene. And so we concluded that sporadic pyoderma gangrenosum, as well as its syndromic presentation PASH, can represent a spectrum of polygenic autoinflammatory diseases. So recently the group of Kaneganti, a first-class group of immunologists from USA, using a mouse model, demonstrated the involvement of the IL-1 alpha pathway in neutrophil dermatosis, indicating a new potential target in refractory cases of PG and neutrophil dermatosis in general. So finally, there is a contributory role of the adaptive immunity and adaptive immunity dysfunction in neutrophil dermatosis, as demonstrated by in these two papers. On the left, a paper of my group, and on the right, a paper published by the group of Emmanuel Maverakis. So the syndromes, there is PAPA, characterized by the triad of PG, acne, and arthritis, and PASH, which is characterized by the combination of pyoderma gangrenosum, acne, and hidradenitis suppurativa, with the possible presence also of arthritis, and so the acronym is PAPASH, and also SAPHO syndrome, which is a condition well known among dermatologists, but also among rheumatologists and so on. So PAPA is due to mutations involving exon 10 and 11 of the PSTP1 gene, leading to the autoinflammatory process. And so this paper recently published by the NIH group demonstrated that a marker of true PAPA can be IL-18, which is overexpressed in true PAPA and correlates with PSTP1 mutations, and these can help in distinguishing true PAPA from PAPA-like conditions. So PASH, I would like to draw your attention to the very impressive clinical picture, dramatic clinical picture of this patient with widespread ulcerative and vegetative PG, as well as acne. And in this young lady, there was also evident HS leading to hypertrophic scarring. In this patient, we found a novel mutation of the PSTP1 gene, and this patient had also arthritis, and so we coined the acronym PAPASH for this young lady, and this acronym had a great success in literature, also due to the novel discovered mutation. So Sweet syndrome is the queen of neutrophil dermatosis. So as you know very well, there is a typical rapid onset of skin lesions associated with fever and neutrophil leukocytosis. And there are three main variants: the classical one, the malignancy-associated Sweet syndrome, and the drug-induced Sweet syndrome. Here you can see the very typical lesions, which are plaque type lesions involving the head and neck, and also atypical targetoid lesions, as you can see in the slides. There are many variants, the bullous one, the pastoral one, the ulcerative one, the subcutaneous, an intriguing variant of Sweet syndrome. Here you can see the patient with this condition, my patient with subcutaneous Sweet syndrome, and the giant cellulitis-like variant described by the friend of mine, Luca Boradori. And so in Sweet syndrome, we demonstrated the overexpression of a number of pro-inflammatory cytokines, such as IL-17, possibly representing a target for new agents blocking this cytokine. So, amyotrophic pustulosis of the folds, a very fascinating entity characterized by pustular regions typically involving the folds, the skin folds, either major and minor folds, as well as the anogenital area. And so this condition was further described in combination with lupus erythematosus, systemic lupus erythematosus, but we had patients, sporadic patient or patient associated, or cases associated with other autoimmune diseases or autoinflammatory diseases, for example, inflammatory bowel diseases. And so I define this condition the princess of neutrophil dermatosis due to his young age, because this entity was first described in 1995. So also I and my group demonstrated the role of autoinflammation also in this rare neutrophil dermatosis. So GPP is another important form, potentially threatening condition with acute onset and widespread pustular lesions associated with erythema, diffuse erythema, and so this form is associated with fever, fatigue, and other systemic symptoms, and it can be regarded as a variant of psoriasis, but in my opinion is more correct to classify it in the context of neutrophil dermatosis as a prototype of superficial or epidermal neutrophil dermatosis. There are forms with or without systemic inflammation and forms with or without plaque psoriasis, and these suggest that the two conditions are not completely distinct, but there are not two completely separated worlds, but there are possible overlapping between psoriasis vulgaris and GPP. Here you can see a condition, DITRA, which is due to mutations, so a genetically determined condition in which there are mutations involving the antagonist of the receptor of IL-36, which is a cytokine playing a pivotal role in the pathogenesis of these conditions, so GPP in general. And so this slide is nice, in my opinion, because it demonstrates, it shows that the pustular regions are driven in particular by cytokines belonging to the IL-1 family, such as IL-1 alpha and IL-1 beta, but also IL-36. In contrast, as you know very well, in the pathogenesis of plaque psoriasis vulgaris, there is a major driver which is represented by the IL-23 Th17 axis. So in this slide you can see the overexpression of these cytokine IL-36 in lesions, in skin lesion of GPP, and so these cytokines is regarded now as the major driver in the pathogenesis of GPP. Okay, to finish the therapeutic approach to NDs, there are classical regimens, including systemic corticosteroids and immunosuppressants, in particular cyclosporin, which represents the gold standard in the treatment of neutrophil dermatosis. This is still the gold standard treatment, but there are also modern treatment options targeting key cytokines such as IL-1 and of course tumor necrosis factor alpha, in particular for refractory cases, but this agents are off-label, and the treatments under development, such as those blocking cytokines such as IL-17, IL-23, IL-36, which are all overexpressed in the lesional skin of patients with PG and neutrophil dermatosis in general. So there is an unmet need of trial with new drugs. On the left, on the right, you can see the trial, the stopgap, which is one of the few randomized controlled trial in PG. The authors, this paper was published and this study was conducted by a friend of mine, Tony Omerod, and the authors concluded that prednisone and the cyclosporin are similar in terms of efficacy in treating pyoderma gangrenosum, but so systemic corticosteroids are burdened by more severe side effects as compared to cyclosporin. So on the left, you can see an algorithm for the treatment of pyoderma gangrenosum, which is a little bit complicated, but we published this algorithm in this paper of my group, published in the American Journal of Clinical Dermatology. So very shortly, there is the standard of care represented by systemic corticosteroids alone or in combination with cyclosporin. In case of refractory cases or highly relapsing cases, it's possible to use a number of biologics which remain, however, off-label agents in treating this condition. So there is an unmet need of new trials with new drugs, biologics, selective biologics for target therapy in PG and neutrophil dermatosis in general. This is a paper published by a network, an international network, coordinated by a friend of mine, Alex Ortega, who is an associate professor of the Oregon University, working in Portland. And so we identified in this paper items for the eligibility of the patients in trials for pyoderma gangrenosum. So I would like to stress the fact that around 30% of the patients may be unresponsive to first-line agents, and in particular, and also there is an unmet need of long-term control of the disease. And so I would like to conclude with these take-home messages. So neutrophil dermatosis are a huge spectrum of diseases characterized by accumulation of neutrophils in the skin and rarely in internal organs. And so there is an unmet need in terms of a measure, to clarify better the pathogenesis of this condition, and unmet need of new agents to treat the percentage of cases which are resistant to conventional treatment, and also an unmet need for drugs, allowing a long-term control of the disease. So thank you very much for your attention. This is the Cathedral of Milan, my city. Thank you very much.
Good evening, Professor Marzano. Can you hear me?
Good evening, yes.
Okay, thanks. It's always special with the technique.
Yeah.
Thanks again for this very nice, complete presentation. It's always impressive with all your knowledge and know-how in the presentation. Thanks a lot. For the moment, I did not get any question for you in the chat, but if you don't mind, I have a question for you. For the patient you had with a pyoderma gangrenosum on imatinib, did the lesions of the pyoderma cured just by stopping the imatinib, or was there other treatment necessary?
Yes, in that case, we treated the patient just with the stopping the drug, the imatinib. But yes, with topical treatment, but just to treat the superinfection. So with just antibiotics, both local and systemic antibiotics, but without, immunosuppressive drug, because this patient had a chronic myeloid leukemia, and so we wanted to avoid to use immunosuppressive agents. We use just local and systemic antibiotics, and upon stopping the drug, there was complete resolution. But after some months, in reality, yes.
It's impressive because sometimes with the other skin diseases or reactions that we see to imatinib, it's often a problem. We don't always see the regression after stopping, and then it's difficult if you need immunosuppressive treatments in those patients.
Yes.
So
I fully agree. I fully agree with you, because I had patients with lichenoid reactions to imatinib, which are common, and they are very unique because the histology is often a combined histopathological pattern of lichen planus and of psoriasis, and very, very peculiar from a histopathological point of view. And I agree with you that the lesions are often refractory. In that case, the resolution were very, very low. There was a long time to achieve a complete healing of the lesions. But yes, we wanted to avoid the immunosuppressive agents to treat these patients. Yes.
And another question, what would be your choice of biological for PG if anti-TNF is not working? What would you choose for the moment?
Yes. I think that. So I showed you the suggested algorithm published in the paper in American Journal of Clinical Dermatology. And so systemic corticosteroids remain the gold standard in the treatment of the disease, or also cyclosporine, or also a combination of these two drugs. Then I agree with you in that the second step is represented by tyrosine factor alpha inhibitors, because yes, this cytokine is involved in the pathogenesis of the disease, and we know very well, we are used to treat patients with this category of drugs. I think that in case of a resistance to tyrosine factor alpha agents, it's possible to consider the anakinra, which is the agent blocking the receptor, the IL-1 beta, so the antagonist of the receptor, the IL-1 beta, which is a drug, safe enough, and also so not so expensive, because another option is represented by the monoclonal antibody against IL-1, canakinumab, but canakinumab is a more extensive drug, and so. But there are cases, so a small cohort of patients treated with this agent, canakinumab, by the group of Lars French, paper published in BJD, I think, or JAMA Dermatology, and so it's probably a more effective solution, a more effective therapeutic option, but particularly expensive. And canakinumab, in contrast, anakinra is a useful and a safe drug, and also a drug characterized by less important costs. And then probably in the near future we will use agents such as IL-17 blocker, but so we will present a case in which I don't want to anticipate, but my co-worker Carlo Alberto Maronese will present a case of PG, drug-induced PG, very peculiar, in which there is a role of an so a triggering factor was a drug blocking IL-17. But I don't want to
We're curious to see that later on.
Yes.
Thanks.
Yes. yes, yeah, absolutely. And then, so I think that another step could be represented by IL-23 blockers, because so there is a role also of this cytokine in the pathogenesis of the disease. And so there is just a case published some years ago by Emanuela Guenova, who demonstrated the overexpression of IL-23 dilisolastin of a patient with refractory PG, and she used ustekinumab, so the IL-12, IL-23 blocker, to treat these patients. But so I think that selective drugs, selective inhibitors of IL-23 may be useful and probably more effective in treating in PG patients, in particular in case of problems with IL-17. But this is the topic covered by my co-worker, Carlo Maronese.
I agree, and probably it will depend on the patient. If there is IBD underneath, you probably will go to IL-23 and not IL-17.
Absolutely.
It will depend on the background.
An important point, we have to avoid to use IL-17 blocker in patients with an underlying IBD, because this drug can exacerbate the underlying IBD in case of association with IBD. Of course, yes. And this is the fact that probably also in PG there are different endotypes in which a pathway driven by a certain cytokine is predominant. This is the case in particular of HS, but in a certain sense also of PG, to have different endotypes of the disease and a predominance, a pathway in a certain patient as compared to another one. And there is also the possibility to have a switch to a pathway to another one, from a pathway to another one in terms of,
so like in the patients with PASH and PAPASH, maybe the IL-1 receptors are even more effective than in,
absolutely, I fully agree, yes.
Very interesting. It's a very intriguing domain. I agree with you. Thanks a lot.
Maybe yes.
I have another question.
I'm joining to my co-chair to thank you and also to congratulate you for the quality of the data you have in these diseases. So to complete the comment about inflammatory bowel disease, are there data from studies in the field of inflammatory bowel disease to evaluate, in fact, the effect of anti-TNF against placebo in neutrophilic dermatosis? Because you reminded us that there are not randomized clinical trials are lacking in the
yes. In reality, there are just few randomized controlled trials. So the stopgap trial published by the friend of mine, Tony Omero, who compared cyclosporine and methylprednisolone, concluding that the two drugs are equal in the efficacy, the effectiveness, but probably cyclosporine has to be preferred due to the less side effects as compared to systemic corticosteroids. And there is a trial on infliximab, which is the other controlled trial. So infliximab would demonstrated to be, which proved to be effective in pyoderma gangrenosum in probably 30 cases of patients with PG, and so infliximab proved to be superior as compared to placebo, and because the trial was double-blinded and placebo-controlled trial, and this is the second controlled trial published up to now, but there are trials ongoing with IL-17 blockers, and probably there are other trials planned with different biologics by the companies.
Okay. Thanks a lot, Professor. Thanks also for being here with us now, from coming back to us. So I think we'll now try to join Professor Zouboulis.
I think that the issue with the connection, it's not very robust. I see on my screen sometimes we lost Zouboulis, sometimes Zouboulis is back. It seems that right now we cannot unfortunately reach him. So I will take the question from Dr. Julie Sarens. So I read her question to share it with the audience. So in the study showed with apremilast, so the RELIEF trial so she noticed that the placebo group did improve too, and the question was, were they only treated with placebo or in combination with topical therapy? So in my memories, in the RELIEF trial, topical therapy was not allowed during the double-blinded phase. I have to tell you that what is quite astonishing in the design of the trial, that when you look at the baseline characteristics, in the two groups, there were only around 55% of patients who were being treated by colchicine, and only 15% of the patients which have been treated with topical steroids. So one question I would like to have addressed to Professor Zouboulis is the possibility to combine colchicine and apremilast, which is quite logical from a physiopathologic point of view. But you are aware that some of the adverse events that you can undergo with either colchicine or apremilast are quite the same, like diarrhea. So I think that the possibility to combine the two drugs will be quite limited. I don't know if you have some experience in this combination.
Well, we do have experience in two patients where we combined. I never start the two together.
Yes.
So if colchicine doesn't work, I first stop colchicine and start apremilast to see whether it's tolerated. But we do have patients where apremilast works, but not enough. And when we add the colchicine, it's even better.
Okay.
And in the real-world data that is published now already about apremilast, in those data you find quite a lot of combinations in these groups. So I think it's possible in certain patients, but of course you have to be careful for the diarrhea and other side effects. Yes.
What is also interesting in the real-life experience with apremilast is to note the effect on the manifestations of Behçet's disease other than oral ulcers, and there is also interesting data of efficacy for genital ulcers, for skin manifestation like erythema nodosum or pustulosis, and even on arthritis.
Yes, I agree. It's a bit early to say because the data are still limited, but it looks like it would also be efficient on the genital ulcers, the other skin manifestations, especially erythema nodosum. Arthritis might be effective, depends a bit. In the French group it was effective. In the meta-analysis it was not clear. So we're awaiting for more results there in real life. Yes, will be
and
certainly
it is
interesting.
important to remind that the label is only for oral ulcers.
Absolutely. The label is only for oral aphthosis. Okay. I think we will now go on to the clinical cases, where we first have the clinical case of Professor Zouboulis, and then afterwards we will immediately go to the clinical case of presented by Carlo Alberto Maronese, who is a co-worker of Professor Marzano. And then we go further to our both cases, and we will take all the questions of the cases at the end of the session.
And maybe at this time that the connection with Professor Zouboulis will be okay.
Restored, we hope so.
Will be restored.
We're looking forward. Okay.
Dear colleagues, I come back to you to report on a COVID-19 infection in a patient with Adamantiadis Behçet's disease. Looking at the data at the time that the patient has been infected, we had in the general population of 83 million in Germany, 2,346,000 confirmed cases, so 2.8% of the general population at the time, with 65,000 deaths and more than 2 million healed. At the same time, the German registry of Adamantiadis Behçet's disease has 881 reported patients. This was the first case. In the meantime, we have 14 cases, and the patient has been healed after a severe infection. I have here to notice that this patient, who has been infected in the year 2020, was the only patient that had to be treated as inpatient and had a severe course. The rest 13 patients that we have evaluated since 2020 to 2022 have been patients that had a very mild disease, and they all healed without any sequela and did not need to be treated as inpatients. It was a 50-year-old athletic German male patient. He was a very heavy smoker. He had recurrent oral aphthous ulcers since the childhood, so 2 points according to the international criteria. Recurrent monoarthritis sulcans since 2010, but this is not a diagnostic criterion. A recurrent erythema nodosum since 2012, 1 point. Leg vein thrombosis 2012 and 14, so recurrent, 1 point. Since 2019, gastritis, and he was both negative regarding the pathogen test and the HLA-B51. So he had a score of 4, which is at the border. It was indicative for Adamantiadis Behçet's disease, but it was not confirming Adamantiadis Behçet's disease. You see here the criteria. You need 4 or more criteria. So 4 is the border where you can suspect the disease. From more than 4 criteria, you have rather a secure disease, and the sensitivity in Germany with this new criteria is very high, 88.6%. The patient has been treated for his major disease, Adamantiadis Behçet's disease, with azathioprine in changing concentration, changes doses from 50 bis 150 mg per day, colchicine 0.5 to 1 mg per day, and he had local tetracycline and the oral mucosa. From November 2019 to February 2020, he had no specific lesions of Adamantiadis Behçet's disease. Suddenly, in February 2020, he had a severe pharyngitis, followed by a course of severe oral aphthous ulcers. In March 2020, he was diagnosed as SARS-CoV-2 positive with pneumonia, respiratory insufficiency, fever, dry cough, acute hepatitis. So the treatment has been discontinued, the treatment for Adamantiadis Behçet's disease. Reactive arthritis, he has received diclofenac for that, intensive care with anticoagulation, intubation between March and April 2020, and he has received antiretroviral treatment with lopinavir, ritonavir, and ribavirin. After his release from the intensive care and the hospital, he has received since May 2020 apremilast 60 mg per day, and this was given as a first period for 4 months until the end of September 2020, and he had no more oral aphthous ulcers and no arthritis. We have evaluated through our international working group of the International Society of Behçet's Disease the situation regarding the COVID infection in patients with Adamantiadis Behçet's disease worldwide. And it's interesting to see that from Japan to the Netherlands, with an exception, of course, of Netherlands in one study, the majority of the patients that we have a lower rate of infection than the general population. Probably because patients with Adamantiadis Behçet's disease have taken care of themselves by isolation in order not to be infected. We have produced a consensus report on Adamantiadis-Bexte's disease and COVID infection of the International Society of Bexte's disease, where we consider that the prevalence of COVID infection in patients with Adamantiadis-Bexte's disease is apparently lower than that of the general population. This may be due to the fact that the patients have been especially careful with social shielding. However, we believe that underestimation is also possible. Now, following the COVID infection in the disease in the last 3 years, having only 14 patients, especially with mild cases, we believe that is indeed the case that we have lower rates. It is not underestimation. We have lower rates of COVID infection in Adamantiadis-Bexte's disease. Again, probably because of social shielding. Adamantiadis-Bexte's disease appears to be not associated with a more severe course of COVID infection. Now we can confirm it. It's not associated with a more severe course. The treatment of the disease with low-dose prednisolone, 10 milligram per day or less, and or biologic, especially TNF-alpha inhibitors, does not increase the risk of COVID-19 infection. Now we can confirm it after the follow-up of 3 years, and does not induce a more severe course. So we have to continue the treatment if it's done despite the COVID-19 infection. The treatment initiation with high-dose prednisolone, cyclosporine A, methotrexate, or rituximab should be avoided, if possible, during the pandemic through the concern of increasing COVID severity. We have seen this with the treatment of other diseases. In the meantime, all our patients do not receive cyclosporine, methotrexate, or rituximab, so we cannot say if this is the case in the disease, but in any case, we don't have any severe cases. And patients who already have received high-dose prednisolone, methotrexate, cyclosporine, or rituximab should practice social shielding to avoid an infection due to the fact that these drugs have been justified as possible for a more severe course of COVID-19. We still do not know what effect, if any, vaccination has on Adamantiadis-Bexte's disease and vice versa. Up to now, and since we have a vast majority of our patients vaccinated, we have not seen, at least in Adamantiadis-Bexte's disease, any contradiction. The benefits versus risks should be considered at the individual level, but we believe that the benefits at the moment are higher than the risks. The treatment with biologics appears to be compatible with the SARS-CoV-2 vaccination during remission of Adamantiadis-Bexte's disease or low disease activity and should not be interrupted. The treatment with biologics appears not to compromise a SARS-CoV-2 vaccination. It may be advisable not to vaccinate during a significant flare, but you can vaccinate during the remittance of the disease, and serological confirmation of successful vaccination is recommended in order to see if the immunological situation of the patient has allowed development of protective antibodies. National self-protection and hygiene measurements should be adhered to. Self-protection with masks is recommended even despite vaccination. I think the self-protection with mask is the most important protection measurements for the general population, of course, for our patients. And of course, these advices do not replace the physician's decision, your decision on each individual patient who has to be evaluated accordingly. And again, I would like to thank all the associations that support our work of the German Registry for Adamantiadis-Bexte's disease, and especially the European Reference Network Scheme, of which we are a member, the German associations, especially the Middle German Competence Network of Rare Diseases, and of course our group from our medical center as coordinator of the Acquired Immunological Low Prevalent and Complex Adult Diseases of the Skin, the Allocate group inside the ERN scheme. Thank you very much for your attention.
Good evening, dear colleagues. My name is Dr. Carlo Alberto Marronese, and I'm very grateful to Professor Marzano for granting me the opportunity to present you this intriguing clinical case. So, heptadecaphobia, such a strange word to begin with. It means fear of the number 17, which is tied to some forms of superstition in several countries. But let's see what we mean by that. So, this case revolves around a 51-year-old male individual whom we had known and followed for many years in the psoriasis-dedicated outpatient service. As a matter of fact, he had quite a challenging cutaneous picture to begin with, which had proven refractory to a number of treatments qualifying for the definition of a multi-failure case. At some point, we decided to switch him to an anti-IL-17 receptor agent, achieving rapid clearance of his plaque psoriasis. 10 months later, however, he came back feverish with disseminated cutaneous ulcers and ulcerated nodules that had been present for 3 weeks, according to him and his wife. Abundant purulent drainage was also noted. His medical history was significant for past ictus cerebri, which occurred 3 years before presentation. Indeed, little remained of his psoriasis, with but a few erythematous desquamative lesions on his hands. However, there was a much more pressing issue at hand, as you can see. Although a presumptive clinical diagnosis of PG, pyoderma gangrenosum, was made as soon as those ulcers were seen due to their typical appearance with erythematoviolaceous undermined edges and abundant purulent drainage, a thorough laboratory workup was ordered in order to rule out an infectious etiology or lymphoproliferative etiology. These standard assessments comprised the complete blood count, inflammatory markers, kidney and liver function tests, and the results were mostly unremarkable, with the notable exception of elevated CRP, erythrocyte sedimentation rate, and absolute neutrophil counts. Procalcitonin was negative, as were blood cultures. Simultaneously, an incisional biopsy was performed for culture and histology. The microbiology report was negative for bacteria and fungi, while the pathology report revealed a dense inflammatory infiltrate with marked neutrophil predominance and epidermal and dermal necrotic foci. Well, this was the appearance of the H&E slide, showing an abundance of neutrophils at the ulcer border. No microorganisms were revealed by special stains. Summing up, with the aid either of the 2019 Paracelsus score or the 2018 Delphi consensus, all of the pieces of the puzzle seem to suggest a diagnosis of PG. Considering all the aforementioned clinical, pathological, and laboratory features, our patient scored a total of 15 in the Paracelsus score, where, just as a reminder, 10 or above is sufficient to establish a diagnosis of PG, and had both the major and 6 minor criteria of the Delphi consensus, where, just as a reminder, presence of the major histologic criterion and 4 minor criteria is enough to make the diagnosis. Accordingly, a definite diagnosis of pyoderma gangrenosum was rendered, and treatment with the anti-IL-17 receptor agent was promptly discontinued as a caution. The patient was managed in a pretty much standard manner with high-dose prednisolone and in association an anti-tumor necrosis factor alpha agent, infliximab, and was later on switched to adalimumab. a complete response was slowly reached over the course of the next 7 months. Now, that being a peculiar case, we ask ourselves, what does the evidence, the currently available evidence at least, tells us? Well, the first lesson is that we are not alone. Other cases of paradoxical PG presenting in the setting of an anti-IL-17 treatment for psoriasis have been reported, with wide variation in time to onset of PG, as a matter of fact. Interestingly, in all these cases, psoriasis seemed to be well under control when PG emerged. In the slide, we can see a case with ixekizumab and another case with secukinumab. Just for the record, there are multiple cases that occurred with secukinumab. And we're not alone in a very specific sense in that not only secukinumab or ixekizumab, but also brodalumab, as in our patient, was regarded as the culprit drug in a case, in this case by Sadik et al. Curiously, another neutrophilic dermatosis of the superficial kind preceded the onset of PG in this specific case, that is, palmoplantar pustulosis. Okay, as always, when we take a look at the full picture, things become further complicated. Indeed, many cases of PG have been managed successfully with either anti-IL-17 or anti-IL-17 receptor agents. So it's not easy to just point our finger at a culprit class of drugs. It's more nuanced than that. Publication bias in this case looms at every angle, and at this time it is not possible to reliably interpret these conflicting findings. Moreover, no randomized controlled trial on IL-17 inhibitors have been ever completed in PG, as you can see from a quick search, a quick look on trial.gov, nationaltrial.gov. Unfortunately, no predictors of success or failure have been proposed in PG patients either. So, at this point, we asked ourselves if this unlucky patient was, so to speak, destined to experience such an unfortunate complication, such an unfortunate adverse event. We took some blood and salivary samples and performed whole exome sequencing to get a glimpse of his genetic background. We were persuaded that this kind of investigation could give us a better understanding of what was going on. Well, two polymorphisms emerged in heterozygosity, and these two are well known in the literature but never have been reported in relation to PG. These lead to increased levels of IL-6 and IL-10, respectively. Well, the following is just a speculation, of course, but it's tempting to hypothesize that higher IL-17, IL-6, levels may have determined an increase in Th17 cell polarization. As a matter of fact, the presence of TGF-beta along with the IL-6 grants the possibility for naive T cells to be skewed towards a Th17 phenotype. So in this very complex context, and in the context of our patient, an artificial blockade of the IL-17 axis may have altered physiologic feedback mechanisms and exacerbated Th17 cell activity via compensatory loops. Indeed, if IL-6 acts as a regulator skewing T cell polarization to Th17, and we added brodalumab to the mix, we may have caused a disruption of a physiologic negative feedback mechanisms. And this is what these authors also hypothesized for a case of paradoxical PG induced by secukinumab. Just few quick, very interesting and noteworthy points to me. No paradoxical cases of PG have ever been observed to date with the IL-12 and anti-IL-23 agents, and cases of paradoxical PG triggered by anti-IL-17 agents are successfully managed with the latter. Well, we know that anti-IL-12 or anti-IL-23 agents act much upstream respective to anti-IL-17 agents. So, we could hypothesize that a block upstream to this very influential axis in the pathophysiology of PG may be more beneficial than acting downstream, where we could disrupt some regulatory ways and some feedback mechanisms related to IL-17. In conclusion, drug-induced PG remains a continuing conundrum, with a number of medications suspected to be pivotal in PG induction. And I know this is a bit off topic, but just as an example of the unexpected association between rituximab-induced PG and vulvar localization further underscores the importance of unraveling the mechanisms of these unusual cases, as they may hold, in their peculiarity, the key for understanding also sporadic PG. So, our findings are far from being conclusive, and many questions remain unanswered, open. What is the role of the documented IL-10 polymorphism? Is it significant? And why did his psoriasis, the psoriasis of our patients, but also the psoriasis that other patients had before experiencing paradoxical PG, stayed under control? Well, all of this further highlights the need for a much more detailed look that can be provided only by further investigations on paradoxical PG. Well, I thank you for your attention, and thank you again to Professor Marzano for granting me this opportunity. Good evening.
Okay, so now it's a pleasure. It's my turn to present one of our patients. And it's this male patient who came to us in 2019 for the first time. At that time point, he was 74 years old, and he had already 6 months regular bouts of these skin lesions that stayed for a few weeks and disappeared without rest pigmentation. And those lesions were like urticaria on the trunk, some bigger lesions on the hips and the glutei. And biopsies were taken. In the one case, it showed an image compatible with neutrophilic urticaria. On the other lesions, it was an image compatible with urticarial vasculitis. In addition to the skin lesion, the patient also developed a symmetric polyarthritis of both the small joints and the medium joints, and sometimes episodes, like you can see on the picture here, of a red eye, which was then confirmed by the ophthalmologist as an episcleritis. And together with the episcleritis, he had this periorbital erythema and edema. He also had general constitutional symptoms of fatigue, and he lost about 6 kilograms in the past year. And during the episodes of skin lesions, he felt feverish, and the measured temperature was between 37.7 and 38.2 degrees Celsius. It was interesting to notice that 2 years before all of this started, he had a quite unexplained episode of deep vein thrombosis in the right leg and a pulmonary embolism. On the lab, he had raised inflammatory markers, he had a hypergammaglobulinemia that was on multiple occasions clearly polyclonal, so no monoclonal component, and he had a macrocytic anemia, no leukocytosis, no thrombocytosis. So taken together, we had a male with an adult onset inflammatory disease with polyarthritis, episcleritis, and skin lesions that were on biopsy predominant with a predominant neutrophilic infiltrate. Of course, there were other examinations done, especially when you have a male with an adult onset inflammatory syndrome. The first thing to screen are all the possible underlying infections and malignancies. That was repetitively done, and there were no signs of infection of malignancies found. We screened for other systemic diseases, but at the end, I remember you, we are in 2019, we had a diagnosis of an undifferentiated autoinflammatory syndrome. We thought one moment of Schnitzler disease, but if you look at the diagnostic criteria for Schnitzler, you need monoclonal IgG or IgMs, which we could never find actually in this patient. But since we excluded the infections and the malignancies, we started treatment with systemic steroids, and he responded very well actually, but we needed quite high doses to keep the response. Every time we got lower than 60 milligrams a day of methylprednisolone, he relapsed. So there was clearly a need for steroid-sparing agents. We tried quite a lot of them, but there was no effect with colchicine, no effect with leflunomide, which was especially given for the arthritis, and no effect with methotrexate. Finally, a trial was given with anakinra, the IL-1 receptor antagonist we already mentioned earlier, but this had no effect whatsoever on the inflammation or the arthritis, and we even saw a big severe skin reaction after this IL-1 receptor antagonist. During the further follow-up in December 2020, in addition to the complaints he already had, he also developed episodes of polychondritis of the ears and the nose. So it looked like relapsing polychondritis, and based on some cases in the literature with positive effect of anti-TNF-alpha, the patient was treated with infliximab, where the first 3 months we thought that this might have been a good response because we could taper the methylprednisolone to 6 milligrams a day, but then again he relapsed. So we needed other treatments, we needed to search further. And then in December 2020, this publication arose from the group of Peter Grayson, where they described a new autoinflammatory syndrome in adult patients due to a mutation in the UBA1 gene, and they called it VEXAS syndrome. VEXAS is actually an acronym. The V stands for vacuoles that can be found in the myeloid or the erythroid precursor cells. You can find them in the blood or in the bone marrow. And actually these patients, they have an acquired, so a somatic mutation in the UBA1 genes in the myeloid cells. This gene is located on the X chromosome, and that's why we found the disease in men. And the gene encodes for the ubiquitin-like modifier activating enzyme. And it gives an autoinflammatory syndrome in adult male patients, characterized by fever, constitutional symptoms, often skin lesions, chondritis, sometimes lung infiltrates, vasculitis, thrombotic disease, and remember our patient also had a history of thrombosis, macrocytic anemia, and inflammatory lab. So after this publication, we put a few things together in our patient. We had the skin disease, the raised inflammatory markers, the macrocytic anemia that persisted. He had the thrombotic event in his medical history. Bone marrow was done before, but now we asked to relook at it, and they find the myeloid vascularization was present in the patient, but there was no real myelodysplastic syndrome. We sequenced the Sanger sequencing of the UBA1 gene, and we indeed found a mutation. So great, we had a diagnosis for our patient. This was a VEXAS syndrome. Did we have a treatment then for our patient? Well, unfortunately not. And now, 2 years later, we had quite a lot of other publications since this first report in the New England Journal of Medicine. And we still are at the stage that these patients are generally steroid dependent, that there is no clear or only sporadic responses with the classic DMARDs or even with anti-IL-6 or anti-TNF-alpha. And as in our patient, other cases have been reported where you have exacerbation of the disease with anti-IL-1. Concerning the prognosis in a few cohorts, but especially in this cohort from different French groups of 116 patients, you see that the prognosis is not so good. They have 16% mortality after a median follow-up of 3 years. The main causes being infectious problems or the evolution of the myelodysplastic syndrome. There are certainly new trials and new studies coming for treatment, and probably the best thing to do will be in these patients to target the clone. Remember, it's an acquired somatic mutation in the myeloid cells, and it's probably there that we should treat to get the best response. We can do this with medication, anti-methylating agents, or with stem cell transplantation. And concerning the anti-inflammatory agents, well, the steroids are still number one to be used. And from all the other ones, probably the JAK inhibitors are the most interesting ones. And within the group of the JAK inhibitors, the last results support especially the use of ruxolitinib as JAK inhibitor. Our patient, for the moment, is on tofacitinib as JAK inhibitor, so not ruxolitinib, because we started already in July 2021, and at that time point there was not the clear data that ruxolitinib might be better than tofacitinib. But actually, with the tofacitinib on board, we could decrease the methylprednisolone to an average of 6 milligrams a day, reducing the inflammatory process. He had no problems with skin involvement or chondritis, but he still has sometimes periods of arthritis. He has a clear progressive microcytic anemia, and up till now, we still have no evidence in his case of hematoclonal process. But we have to watch this closely because this might be just a matter of time. He's also on rivaroxaban for actually prophylaxis for the thrombotic events. So a message: think of VEXAS. If you have a male patient with new onset inflammatory disease, and especially if you have the combination with a clonal hematopoiesis, and as you can see, a lot of patients, more than 80% of the patients in all the cohorts that have been published, have skin manifestations. So I think as a dermatologist, we can be an important group of doctors to signaling the disease. And there are two nice reviews about the skin manifestations in VEXAS. What can you see? Well, it has been described as a bit like in our patient with persistent urticaria-like lesions, sweat-like lesions, erythema nodosum, urticarial vasculitis or pan-like lesions. And these types of lesions have been biopsied, and most of the time you have a predominant neutrophilic infiltrate. The periorbital erythema and edema that we had in our patient has also been described in a few other patients, just like livedo reticularis. These lesions have not been biopsied. In our cohort in Leuven, these are 8 patients. We now have already 10 patients. All of the patients had indeed skin disease, and most of the patients also had the relapsing polychondritis. So a male patient with relapsing polychondritis is also an alarm for VEXAS disease for the moment. A few other examples of our patients is this male patient who was already in our department for a longer time, who had a well-known myelodysplastic syndrome, and regularly these lesions that were diagnosed as being Sweet syndrome, both clinically and histopathologically, but now we found the UBA1 mutation. Another patient was this male with an inflammatory syndrome, these skin lesions. Diagnosis was confirmed, we found the mutation, but all the biopsies that have been taken up till now from all the skin lesions always came back as lymphocytic infiltrate. Actually, it always suggested a diagnosis of cutaneous lupus. The same with this patient, a proven vexus with these kind of lesions, and the biopsies always came back as cutaneous lupus. So I think indeed the skin lesions have a predominant neutrophilic infiltrate, and probably those neutrophils are a derivative of the clone, the myeloid clone. But it does not mean if you find a predominant lymphocytic infiltrate in your patient that you should exclude vexus, I think, for this moment. So just remember, vexus, it's a hemo-inflammatory disease driven by somatic mutations. Skin lesions are very often present and are a very visual sign, so we need to recognize it. Most patients for the moment remain dependent on steroids, are refractory to the classic biologics and DMARDs. Maybe the JAKs are the best option as anti-inflammatory agent, and probably ruxolitinib within the JAKs. And on the longer term, it might be that the stem cell transplantation will be the best solution in selected patients, of course, because it has a big risk, the treatment on itself. But currently there are phase 2 studies running for those stem cell transplantation in vexus patients. So this was my case, and I'm happy to hand over to my co-chair for his cases.
Thank you very much. So, as the last presentation for tonight, I have the pleasure to present you several cases of atypical vascular venous involvement due to Behçet's syndrome. These cases are not, in fact, properly within the scope of dermatology. Also, you will see that some manifestations are directly seen on the skin. Behçet syndrome is at the crossroads of several categories of immune-mediated inflammatory disorders, vasculitis, autoinflammatory diseases, neutrophilic dermatosis, and to end, major histocompatibility complex type 1 opathies. So the first case is about a 60-year-old man diagnosed with Behçet syndrome more than 30 years ago, after 4 years of what I call diagnostic wandering. So you can see on this picture a collateral circulation on the upper part of the chest. If we come back to the presentation of this patient in the 80s, in 1984, he presented for a fever of unknown origin, plus a brachiocephalic and a superior vena cava thrombosis. The year after, an intrahepatic inferior vena cava thrombosis was evidence. The same year, he developed his first episodes of scrotal ulceration. In fact, scarce episodes of oral ulcers were neglected in the anamnesis. So the patient was diagnosed as a vasculobehçet in 1988. Afterwards, he was lost of follow-up, and I saw him for the first time 2 years ago with the picture that you can see, and on the upper chest, and with this lateral view, you can also see a collateral circulation along both flanks, also on the abdominal wall. So here you can view the left flank. The patient underwent a CT angiography, of which you can see a difficult to interpret reformat for the non-radiologists that we are. And in fact, it shows an occlusion of both inferior and superior vena cava, which is very, very rare atypical presentation of Behçet syndrome. To understand what is new, the new circulation in this patient, when you inject iodine contrast media in this right forearm, there is opacification of intercostal and azygos vein. Then the blood goes to the left renal vein and then to the inferior vena cava. There is a stop without a clear thrombus. Afterwards, there is opacification of intrahepatic anastomosis in the caudate lobe of the liver, and then the blood goes to the right sushepatic vein, which is the only one remaining. And then to the intrathoracic inferior vena cava, and then finally to the right atrium. In the literature, there have been only 2 cases with occlusion of both vena cava, which have been previously reported. The second case is the only one about a patient which is not from a Caucasian origin. So it is about a 38-year-old Moroccan man presenting with a recent swelling of the upper part of the body. The patient had a history of recurrent oral apoptosis for several years. A few days before admission, he noticed a scrotal ulceration and folliculitis of the face and of the trunk. He had already presented such an ulceration 3 years ago, and 1 week before admission, he developed a transitory fever. CRP was elevated at this time. And once again, a collateral circulation on the chest wall was observed. Given the suspicions of Behçet syndrome with superior vena cava thrombosis, a CT angiography of superior vena cava was performed and revealed, in fact, not a thrombosis, but a marked stenosis without thrombosis due to the thickening of the inflammatory venous wall. So this presentation of the superior vena cava syndrome associated with Behçet is very exceptional, since when you have superior vena cava syndrome, it is quite always due to a thrombosis and not to an inflammatory stenosis. So you see here the angio-CT of the superior vena cava with a coronal slide showing the marked stenosis of the vena. The third case, we are coming back to a Caucasian patient with a right ventricular thrombus and a resulting tricuspid valve dysfunction. The patient was, at the time of presentation, a 25-year-old, and the vascular Behçet was diagnosed on the basis of recurrent oral ulcers, pseudofolliculitis with acneiform lesions, recurrent deep venous thrombosis and pulmonary embolism despite oral anticoagulation, and to end, the presence of an intracardiac thrombus in the right ventricle, which was unresponsive to medical treatment based on cyclophosphamide and azathioprine. Even so, the intracardiac lesion was successfully removed by surgical excision. He presented a severe and involving tricuspid dysfunction, which was due to the extension of the fibrosis to the myocardium and the endocardium, with no therapeutic option, either medical or surgical. So he underwent a heart transplantation, and in fact there are only 2 other cases of heart transplantation in the literature which have been reported both in male patients. On this figure you can see the right ventricle thrombosis. On this one, if you see the picture with the color, it's a transesophageal echocardiography with a Doppler study showing the severe tricuspid regurgitation. Now, pathology of the cardiac mass, which was removed. We can see a significant thickening of the endocardium with fibrosis. In fact, strands of fibrosis are extending to the underlying myocardium. In this Masson trichome staining, you can see in blue the fibrosis in the endocardium, and also fibrosis which is beginning to infiltrate the cardiac muscle. The fact that these three first patients are male is representative of the higher relative risk of vascular involvement, which has been underlined in this German paper, whose last author is Professor Zuboulis. So it was shown that the relative risk of vascular involvement consisting in superficial venous thrombosis, deep venous thrombosis, but also heart involvement was higher in men than women across the German Behçet's disease registry, but also in data from meta-analysis coming from a systematic literature review. The last case is the only one about a woman. It was a 50-year-old woman beginning with a non-erosive oligoarthritis, which was seronegative. And in fact, recurrent oral ulcers were not reported on initial anamnesis, which in fact not really addressed this feature. She had bilateral redness and pain for 6 months at the time of presentation, and at this time she was already treated with methylprednisolone and methotrexate with insufficient clinical response. The diagnosis of the ophthalmologist was a bilateral anterior nodular scleritis complicated by corneal opacities. So you can see a very impressive picture of the eye of the patient. This picture is not the patient's eye, but is there to remind you what is characteristic in Behçet's disease uveitis. It's the hypopion. I can't show it with an arrow, but you can clearly see the level of a sterile pus in the anterior chamber. So to summarize the workup, I will show you what was abnormal, what was positive. So she had a persistent elevated inflammatory markers, and also she was positive for HLA-B51. She was started by the ophthalmologist on cyclosporine and mycophenol mofetil with clinical improvement, but not enough, and a persistent of scleral inflammation. Afterwards, she was shifted on adalimumab when the drug began to be reimbursed in Belgium in this indication. And with this new drug, she underwent a complete clinical resolution of ocular inflammation and also of biologic inflammatory markers. Due to the effect of persistent arthritis, methotrexate was reintroduced. But what is in fact the originality of this case? It's this. So while the patient was still under immunosuppressors consisting in methotrexate and adalimumab, we noted a painless reducible mass of roughly 3 centimeter diameter on the right side of the neck. And in imaging, it turned out to be an hypermetabolic phlebectasia of 25 millimeter of diameter, located on the right external jugular vein with a partial thrombosis. In fact, it has never been associated with Behçet's disease, and this case is submitted for publication. This figure summarizes the different types of vascular involvement in Behçet's disease, the most frequent being the superficial or deep venous thrombosis at the level of lower limbs, in 15 to 40% of cases. The intracardiac thrombosis, like described in our short patient, is only found is 1 to 6% of patient, and what is very characteristic is that the thrombosis is at the level of the right ventricle. To end, the arterial involvement, which has been described in 2 to 17% of patients, and in fact, the most life-threatening manifestation of vascular Behçet is the pulmonary artery aneurysm, which can lead to rupture, which is particularly dramatic in patients who are anticoagulated due to deep venous thrombosis. So as conclusions and take-home messages, the spectrum of vascular involvement in Behçet disease is broad and includes severe manifestation like thrombosis of vena cava or even heart involvement. The most frequent presentation of the latter is right ventricular thrombosis. And the dermatologist should be aware of these features, as the patient can present for a collateral circulation of the trunk or cutaneous signs of deep venous thrombosis. What I have called the diagnostic wandering in 3 of the 4 cases lie on the negligence of oral ulcers on the physical examination and anamnesis, and also on the Caucasian origin and ethnicity of those 3 patients. So with these last cases, we can end the presentation and move to the question. And I can't see on my screen any question from the audience. So maybe should I begin with a question to Dr. Carlo Maronese, if he can hear me?
I can hear you perfectly.
Thank you.
Please tell me.
So thank you for a nice presentation and the analysis of the immunopathological mechanism leading to the dramatic presentation of the patient. Have you considered to give anti-IL-6 or anti-IL-6 receptor in this patient, as it acts before it acts on the polarization to TH17 lymphocytes, TH17 lymphocytes?
Well, the switch towards tocilizumab was considered, but was not needed at the time. By the time we got the genetics report, you may be familiar with the timing required for whole exome sequencing. Unfortunately, the genetics information became available to us 5 to 6 months after the diagnosis, and in that time frame, the patient was adequately controlled with adalimumab. So, although we keep that as an option in case of a flare, it was not taken as a management decision, as the patient did not require such change in his therapeutics.
Okay, but you think it could have been after having received the data for the exome sequencing, it could have been a smart option too.
I think it could be an option, but my personal opinion is that cases triggered by anti-IL-17 agents should be managed with anti-IL-12 or anti-IL-23 agents, preferably.
Okay.
So to upstream.
I also have a question for Dr. Maronese for your nice, intriguing case. If I remember well, from the beginning of your case, your patient was first on IL-17 antagonist for the psoriasis, which did not work for the psoriasis, but did not give pyoderma. And then when it was switched to the receptor antagonist, the pyoderma appeared.
Yes.
So that's strange, isn't it?
It's intriguing.
Yeah.
It is intriguing, and it confirms that the role of IL-17 is nuanced, and it adds to the complexity of the case, and it falls in line with other works in which a lot of time in terms of inhibition of the IL-17 axis was required to trigger, reportedly, PG. In some cases, it was more than a year. So it is possible that cumulative effect of the anti-IL-17 and the anti-IL-17 receptor agents determined in time an effect that generated PG. But it is also possible that it's merely a coincidental finding. I do not feel confident enough to exclude this possibility altogether.
Thanks a lot for your nice case.
Thank you, and my congratulations for the presentation of the both of you. They were magnificent.
Thanks a lot. I don't see other questions, but I might ask you, Frédéric,
Yes.
last question. I find it always difficult as a dermatologist when we have patients with Behçet's disease. We know we have to screen for the eye involvement. We often screen when there is a red eye. We send to the ophthalmologist. We ask about the history of thrombosis. We look for thrombophlebitis, etc. But it's difficult to know how far you have to screen your patients for those rare but dangerous vascular involvements. I know there's no clear answer, but what would you suggest?
The clinical manifestation should lead the extent of the workup, because looking at subclinical eye inflammation, there is, in my opinion, very little interest.
So
some ophthalmologists say that sometimes you can see scars of previous bouts of inflammation, but I think it doesn't have an impact on the management.
No, I agree for the eyes, but I find it sometimes difficult if you have thrombotic events. Of course, in Behçet, you should treat them especially anti-inflammatory. But then before starting the anticoagulants, should we do a CT to exclude the aneurysm of the pulmonary artery?
What is called the Hughes-Stovin syndrome, which is an association of deep venous thrombosis and pulmonary aneurysm. So I think it could be of interest. We had a dramatic case of a young patient who was receiving anticoagulants for deep venous thrombosis, which is questionable. As you mentioned, the inflammatory treatment is a cornerstone larger than anticoagulation, and he was transferred from Algeria to adapt the treatment of pulmonary aneurysm, and in fact he has a rupture and he died in a hemorrhagic shock. So probably it will be interesting for patients, for a unique patient to search for pulmonary aneurysm. You should also know that frequently pulmonary aneurysm is accompanied by fever, by elevated inflammatory parameters. So when it is evolving, most of the time it is quite evident that there is something happening.
Okay, thanks a lot. Thanks for being here with me tonight for this webinar. I think we can close up, and I really want to thank all the speakers once again for the nice presentations. But I also really want to thank all the sponsors for the possibility to give these webinars and to continue to provide scientific meetings for our dermatologists. So thanks a lot for all our pharmaceutical sponsors. It's important. And I think we can end by showing you the upcoming events of our society, and I hope we will see you all in March in Brussels for the next BDD days and for the upcoming and later webinars. So I thank you for listening and being with us tonight.